and welcome to the Hccl Virtual Community Health Fair, Matters of Health in Black and Brown. Thank you for clicking in to join us. My name is Ernie Hccl, Chairman of the Board of Directors of Hccl Family Services, Inc. And we are hosting and producing this community event with the support of some community partners and sponsors.
My name is Chiquita Taylor, and I am honored to be the Executive Director of Hccl Family Services. Hccl was founded in 1986 by Dr. Warren H. Stewart Sr. to be the community outreach arm of First Institutional Baptist Church, where he serves as senior pastor. As an independent 501c3 nonprofit community-based organization, Hccl has a legacy of serving the underserved of the Phoenix metro area. We strive to have an empowering impact on individuals and families and their needs in areas such as food, clothing, housing, employment skills training, immigration assistance, and lately in health and healthcare. Our mission is to provide people with knowledge, skills, and support to transform and empower their lives. To learn more about our programs, please visit us at hccl.org, or you can visit us on Facebook or Instagram at Hccl Family Services, Inc. This 2021 Virtual Community Health Fair is focused on providing people with knowledge, skills, and support to transform their lives into healthier ones for their future. In spite of trying to live through the worst public health crisis since the early 20th century. In fact, we are compelled to offer this event now because of the connections or impact of COVID-19 to top health challenge areas in the Black and Brown communities. We are very pleased and honored to present this event of access and resources to the community now, because it is needed now. Now is the time to address issues of disparities, disproportionate impact, access, and solutions. With a short event such as the health fair, we take a small step in trying to address this need at the foundational level with access to resources and information and education. Expect more Hccl health programs and initiatives to follow as we work with our partners to meet the needs of the community.
Now, this fair was designed with a focus on the social determinants of health, particularly in the Black and Brown communities. So as you look through the agenda with its sessions and speakers, you will see a diversity of speakers addressing issues of housing, mental health, diabetes, insurance access, cancer, financial empowerment, to name a few. Over the 3 days, there are approximately 29 speakers covering 20 topics that top the list of community health challenges, including, but certainly not limited to, COVID-19. Some sessions are live, and you will be able to chat with most of the speakers. Some presentations of material are available in Spanish and English. You will also be able to go to the Hope and Health Resource Room and find documents or links to more empowering information. And you can access these services and resources that are available to you in the metro area. The virtual fair is designed to be user-friendly and efficient as you navigate through the site to find and enjoy whatever you register for during the 12 hours of content spread over Thursday, Friday, and Saturday. I do want to thank our sponsors, APS, Hccl University, Banner Health, Dr. Donald and Effie Godbold, First Institutional Baptist Church, Mayo Clinic, Mercy Care, Russ Lyons South Beach International, SRP, United Healthcare, as well as other partners who made this event possible. So we invite you to join in wherever you have an interest. And please don't forget, before you leave, to give us feedback so we know how to improve for the future. I thank you and enjoy the fair.
And don't forget, you can also contact us at fibcoadmin.org or chiquita.taylor@fibco.org. Thank you again for coming, and please do enjoy what we have prepared for you. Be well and be safe.
I'm Phoenix Mayor Kate Gallego, and I'm honored to be with FIBCO Family Services for this 3-day virtual health fair. This year's theme, Matters of Health in Black and Brown Communities, could not be more important or more timely. COVID-19 and the events of the past year have revealed what you already knew, that there are huge gaps and huge opportunities, and that we need to do better. This event to me is full of optimism and setting us on that path to making sure everyone has access to health information, health services, that we put equity and equality at the forefront. Thank you to the FIBCO family for meeting such important and vital community needs. I also want to thank the amazing partners that we have in this event, ranging from Mayo to Valleywise to Banner, service providers including SRP and APS, as well as insurance providers such as United Healthcare. We appreciate your partnership. I hope this event will be a great chance to engage, to learn, and to share what you already know. Also want to thank FIBCO and Dr. Warren Stewart for your leadership over the past year on so many issues, including most recently vaccination. Thank you, Dr. Stewart, for rolling up your sleeves and getting vaccinated in public. I did that with my flu shot, and it's a funny experience, but your leadership is a role model for so many in this community, and vaccination is going to be such a key step to moving forward and getting to that day where we can each safely take off those masks and know that our community is okay. The City of Phoenix, we hope to be your partner moving forward, including at our mobile vaccination sites, as well as the static site at Maryville Community Center, and just work with you on so many issues. We've been glad to partner on nutrition, hunger, safer, healthier Phoenix, but we know we have a lot more work to do. With the momentum coming out of this event, I'm optimistic we will get it done. Have a great experience. Thank you.
Hello, everyone. Thank you very, very much for coming to the Racial Disparities in Heart Disease, What Have We Learned from COVID-19 session for the FIBCO Virtual Community Health Fair. I want to certainly echo the thanks to Ernie, to Chiquita, to Mayor Gallego, and certainly to the senior leadership at First Institutional Baptist Church for allowing this event to take place and to bringing this to you. I think this is a wonderful way for us to cap off the 2021 Black History Month, to make sure that we underscore the need for both spiritual and physical health to protect ourselves and our communities. I'm Dr. Paul Underwood. I'm a cardiologist and medical director of Boston Scientific Corporation, but more so, I am a co-chair of the Community Programs Committee at the Association of Black Cardiologists. It is my distinct honor and pleasure to introduce to you now Dr. Rachel Bond. She is a board-certified attending cardiologist who has devoted her career to the treatment of heart disease through early education, detection, and prevention. She is the system director of the Women's Heart Health at Dignity Health in Arizona. Dr. Bond is co-chair of Women in Cardiology Committee, as well as chair of the Diversity and Inclusion Committee for the Arizona chapter of the American College of Cardiology. She also serves on the Women in Cardiology Section Leadership Council for the National Chapter of the American College of Cardiology, and was most recently appointed co-chair of the Women and Children's Committee for the Association of Black Cardiologists. She holds a faculty position as assistant professor of internal medicine at Creighton University of Medicine. Dr. Bond earned her Bachelor of Science degree from the 7-year accelerated medical program at Sophie Davis School of Biomedical Education, where she graduated summa cum laude. She earned her medical doctorate from New York University School of Medicine. She completed her training in internal medicine at NYU School of Medicine and in cardiovascular disease at Hofstra Northwell School of Medicine at North Shore University Hospital and Long Island Jewish Medical Center in New York. Dr. Bond is the author of several review papers referencing maternal health, sex and gender differences in cardiovascular conditions that predominantly affect women, along with opinion pieces aimed at addressing health equity, reducing health disparities, and promoting professional development of women and minorities in the health science profession. She has a passion for advocacy, education, and mentorship, and has advised as an expert source through news and media outlets. Her clinical interests currently include heart-mind connection, cardiorheumatology, and gender disparities in valvular heart disease. Dr. Bond is a fellow of the American College of Cardiology and a member of the American Society for Preventive Cardiology, the Association of Black Cardiologists, and the American Heart Association. She's a national spokesperson for the Go Red for Women campaign and sits on the board of directors for the AHA. Again, it is my pleasure to offer to you now Dr. Rachel Bond.
Thank you so much, Dr. Underwood, for that amazing introduction. And thank you all for the opportunity. Today, we are going to be focusing on racial disparities in heart health. And I did want to focus predominantly on women, but also understanding the importance of men as well in the mix of this. But most notably, a lot of the things that we see in heart disease are very much so mirrored in the COVID-19 pandemic. And hopefully by the end of this talk, you all will learn that. So in terms of the outline, as I mentioned, we're going to review the current state of cardiovascular disease, but most importantly, the impact a lot of these social determinants of health play on it. Beyond that, we're going to understand the challenges in the management of health, women's health in particular, during the COVID-19 outbreak. And lastly, we're going to leave today with strategies and hopefully solutions to improve the outcomes that we see. So I wanted to actually start by opening this up for a question. And of course, we're going to answer this question by the end of the talk, but I want you to think about this question as the talk kind of lingers on. What does COVID-19 and heart disease have in common? Is it A, they are currently the top causes of death in the United States? B, Black people are more likely to die from both diseases, with social determinants of health being the greatest reason. C, underlying heart conditions, which are more likely to afflict Black people than other populations, can be linked to the most severe cases of COVID-19, or D, all of the above. And as I said, we'll answer this question towards the end. So let's delve into really the current state of cardiovascular disease, and most notably, the role that these social determinants of health play with it. So I always like to begin with this graph because what it really paints a very nice picture of is that heart disease is an equal opportunity killer. Really before the mid-1980s, if you look at this graph, men in blue, women in red, you see that men were dying at much higher rates of cardiovascular disease. And it really wasn't until the mid-1980s where we began to see a steady decline in heart disease in men, but unfortunately an ongoing rise of heart disease in women. And one thing I can say is that what happened in the 1980s were the advent of medications. We had new innovations like angioplasty, where we would balloon open any blocked arteries in the heart. But unfortunately, those management efforts were being disproportionately provided to men and not women. And it really wasn't until the year 2000 when we began to highlight these disparities through the Go Red for Women campaign that the American Heart Association created, such as an awareness campaign to increase awareness that heart disease was the leading threat for women. Beyond that, though, the American Heart Association joined forces with the American College of Cardiology to come up with guidelines and research that were specifically dedicated to women. And what we saw was a steady decline in death from cardiovascular disease. But if you actually look at the graph in later years, we're seeing that there is a trend going in the wrong direction for both men and women. But when we actually focus in on where that trend is going in the wrong direction, we see that from a sex, age, as well as even ethnicity perspective, we have done a fantastic job in decreasing the number of deaths from heart disease in people of all ages and races above the age of 65, as well as all genders. But where we're not doing as good a job, or even where we're seeing a slowing in the decline, and if anything, maybe even a rise in heart disease deaths, actually is in the young population between the ages of 35 to 54, especially in women, especially in Black women, most notably. And before we delve into the why for that, I really wanted to just talk about, as a whole, the African American community. And when we think about the statistics, we know that African Americans have the lowest rates of what we would call ideal components of cardiovascular health, meaning blood pressure control, less likely to smoke, lack of cardiovascular disease, or the ability to eat a healthy diet. Because of this, they have the highest rates of total cardiovascular disease and thus the highest rates of death due to cardiovascular disease. And one thing that captures the nature of health inequities as clearly to date, when it comes to even cardiovascular disease, has a lot to do with the persistent life expectancy gap between the white and Black community that we're seeing. This graph here very nicely shows that in America, at least this was data from the National Vital Statistics Report as of 2017, and this does reflect a lot of the data that we're seeing even as of early 2020. I will highlight now the newer life expectancy later on in my talk. But when we compare white men to Black men, we see that on average, a white male lives about 76 years versus a Black male who lives about 71 years. The same we can see for a white female who lives on average about 81 years compared to a Black female who lives on average about 3 years less at 78 years. And when you think about the contribution of leading cause of death in America, cardiovascular disease being that, it is the leading cause of death for both men and women. But when we separate it into ethnicity and race, we see that it does actually reduce one's life if they are a Black American by almost 1 year compared to their Caucasian counterparts. So there is a disadvantage. And when we think about the most common cause or the most common death related cause of cardiovascular disease, hypertension tends to be the lead. And it does disproportionately affect the Black community. And one thing that's important to highlight is that 50% of Black women above the age of 20 have some form of cardiovascular disease, with hypertension related deaths being the driving factor of that. So what that means is that a Black female is really, in essence, the highest risk population. And for me as a cardiologist, but most importantly, a preventive cardiologist, I like to always understand why. Why are we seeing these disproportionate higher rates of death and poor outcomes when it comes to our Black younger women in general? And when we think about that, let's talk a lot about, well, what about the presentations to the hospital? So overall, when women present to the hospital, they tend to be either present later on in their course, but even when they present, they're less likely to be referred for very life-saving measures, such as an angiogram. An angiogram is a procedure where we're able to actually look at the arteries of the heart and see if there's a blocked artery. If there is a blocked artery, at that same time, we're able to open it up and let the blood start circulating very nicely. But the fact of the matter is that women in general are less likely to be referred for that. Beyond that, they're less likely to be provided a baby aspirin or medications that can lower their cholesterol. And when we look at who had the worst outcomes within the hospital because of the fact that there are these disparities, again, we see that it's targeting women that are 35 to 54 years of age, particularly those that identify as Black. From a discharge perspective, after their hospitalizations, they're also less likely to be referred to something called cardiac rehab. Cardiac rehab is a phenomenal thing where we actually have the ability to monitor your exercise and your ability to kind of progress through your exercise after a cardiac event. Women are less likely to be referred, but most notably, they're also less likely to complete it. So there's something that we as a health system and as a society need to be focusing in on. But even beyond heart disease and someone presenting with a heart attack, we see disparities when it comes to heart failure, which is a weakening of the heart muscle in terms of how aggressive we manage that with medications or devices. We also see this when it comes to arrhythmias, a common arrhythmia such as atrial fibrillation, where you have an erratic movement of the heart, usually at the very top muscle chamber. we know that women are less likely to receive medications that usually help to reduce their risk of stroke, those medications being blood thinners. But beyond that, they're also less likely to be considered for procedures to get them out of atrial fibrillation. We also know when it comes to peripheral arterial disease, the African American community in general usually tends to have higher rates of amputation, meaning their legs being cut off. But most notably, we know that this disproportionately affects Black women because, in addition to having these higher rates, we also know that they may have more atypical presentations of peripheral arterial disease, meaning that when they walk, usually what happens is they have pain in their legs, but these atypical symptoms may actually mean that their symptoms are actually at rest, or for the most part, they may not even have symptoms. And that's where making sure you have a very heightened suspicion and you're doing appropriate screening tools is so important. Beyond that, we see the same when it comes to valvular heart disease. Disproportionately, people of color, as well as women, less likely to be referred for life-saving measures that tend to be much more minimally invasive, meaning where you don't need a surgical procedure to fix the particular valve. Now, one reason, again, these disparities may also be notable is because awareness is lacking. This was looked at by the American Heart Association in 2019 versus 2009. And they saw that in 2009, 65% of women knew that heart disease was their greatest threat. Unfortunately, in 2019, that dropped to only 44% of the population. And when they actually targeted who had the greatest lack of knowledge, it was women between the ages of 25 to 34 who identified as Hispanic and Black. A lot of reasons why awareness may be lacking is because in that younger age population, they could present with atypical symptoms. So when you think about typical symptoms of a heart attack, you think about that elephant sitting on the center of your chest that may radiate to your arm or be associated with sweating. But a third of the time, and most notably in women, they may not have chest pain. They may have dizziness. They may have shortness of breath. They may feel more indigestion or even fatigue. Perseverating and ongoing fatigue that doesn't go away could be a red flag that there may be a pending issue with your heart. Beyond that, though, research is lacking, and we know that when it comes to women in general, they are underrepresented in cardiac research trials, in that only 20 to 30% enrollment tend to be women. But when you actually look at it from a race perspective, we know the Black and Brown community even more so have staggering numbers, probably even less than that 20 to 30% mark. Now, as I brought up, ethnicity definitely factors in when it comes to cardiovascular disease. We very nicely saw that the African American community has the highest rates of poor outcomes because of the fact they have the highest rates of risk factors. But beyond the African American community, we see the same when it comes to South Asians. We see additionally the same with our indigenous population, especially in the state of Arizona in particular, very high rates of cardiovascular disease. And a lot of that is linked to social, economic, and political challenges that they may face. To the same degree, we know that the areas that you live and your proximity to a hospital system does factor in. So more women living in remote residencies, such as rural communities, definitely have much poorer outcomes and higher rates of cardiovascular disease. Income also factors in. And from an income perspective, we know that the lower your socioeconomic status, the higher your risk of cardiovascular disease. One caveat to that is the maternal mortality crisis. And I have to bring that up because we know that heart disease is the leading cause of death for women during their pregnancy and the postpartum period. That disproportionately affects Black women, who are 3 to 4 times more likely to die compared to their white female counterparts. And it has nothing to do with their education or socioeconomic status. So that's a caveat. And we're going to talk about what are more likely reasons, such as these social determinants of health. From a risk factor perspective, it's important to highlight that despite the fact that heart disease is the leading cause of death in the United States, it's something we can prevent 80% of the time. And what makes it preventable 80% of the time are traditional risk factors: your blood pressure, your blood cholesterol, if you're diabetic, if you're obese, if you're physically active. But interestingly enough, those traditional risk factors do place a female at a greater risk of heart disease than if their male counterparts have it. Similarly, if a female is a smoker, she's at about a 25% greater risk of having a heart attack compared to their male counterparts. Beyond that, though, women have more sex-specific risk factors, a lot of which occur during their pregnancy, such as gestational diabetes or elevated blood pressure, preeclampsia, or preterm labor, all of which do place them at a higher risk in the future for heart disease and complications. I like to always talk about anxiety, depression, and stress because those are risk factors as well that are more predominant in women. But beyond that, a lot of the cancer treatment that women do receive, as well as men, such as chemotherapy and radiation therapy, may disproportionately increase one's risk of cardiovascular disease. Fertility, or particularly infertility, having early menopause are also other common risk factors for heart disease. But at the core of this, and when we think about the biggest drivers of all these health outcomes, it's not healthcare alone. In fact, 60% of the time, it has a lot more to do with those social determinants that we talk about: personal behaviors, environment, and societal factors. So where we live, where we grow up, and where we were raised, a lot of which is centered on this historical legacy of structural racism. This is really impactful because even in our larger societies, the American Heart Association in November actually released a scientific statement to say, at the core of the disparities that we're seeing in the Black and Brown population, structural racism has to be within that. And all these social determinants of health are centered around that. And when we think about these social determinants of health, ranging anywhere from income, culture, education, we also know food deserts are a part of it. So we as clinicians can talk to our patients about what healthy meals should be, but if they don't have access to that healthy and affordable care, it becomes problematic. If they don't have access to the ability to safely exercise, it becomes problematic. So it's very important that we're capturing and being thoughtful of these potential social determinants of health. And for me, when we think about the Black and Brown community as a whole, we know that the problem is heart disease is the leading cause. So when we think about what places one at a higher risk of heart disease, we talk a lot about, again, those traditional risk factors I mentioned: the cholesterol, the blood pressure, the obesity, the diabetes, if you're a smoker. Age, absolutely. A male above the age of 45 or a female above the age of 55 is a risk factor for heart disease as well. Beyond that, we talk about race, we talk about these more sex and gender specific risk factors, but imagine adding to that mix these social determinants of health, ranging from one's income, one's access to affordable healthcare, access to food, education, and most notably, this constant discrimination, and with that mistrust that our population experiences. My concern is, what is it going to be doing to the health of those within our community? So let's now dive into COVID-19, because a lot of what we see in cardiovascular disease is actually mirrored in COVID-19. And I think everybody probably by now understands that COVID-19 directly can affect the heart. The way it can is through, more importantly, an inflammatory process that the body produces to try to fight that virus. But in the act of fighting the virus, it also starts to fight the healthy cells of our heart. But beyond that, it has indirectly affected our cardiovascular outcomes too, because many patients are fearing going to the hospital. There's less likely the ability to get preventive care with their primary care physicians because of also the fear of going to their doctor's offices. But beyond that, we know that there are certain medical conditions that place someone at a higher risk of severe form of COVID-19. The CDC talks about this, and it could be cancer, kidney disease, chronic lung disease, diabetes, if you're immunocompromised, obese, if you're an active smoker. But within that also is heart disease. Anyone who has a form of heart disease, ranging from heart failure, coronary artery disease, or cardiomyopathies, are at a much higher risk of having a severe form of COVID-19. But what about beyond that from a demographic perspective? Age absolutely is a factor. We know those above the age of 65 are at a higher risk of having a severe form of COVID-19, especially once you get to those above the age of 85. But what about race and ethnicity? And this has been very nicely shown that when it comes to actually the number of cases per 10,000, the Black and Brown community in the United States of America are 3 times more likely to become infected as compared to their white colleagues. But beyond the infection, what about death? We actually see that Black people aged 35 to 44, so these are very young people, are 10 times more likely to die from COVID-19 again, compared to their white counterparts. And why is that? Again, here's the why. It's a multitude of reasons. One very well may be that the occupation of the Black and Brown community are those that are essential, meaning that they're at a higher risk of contracting COVID-19. And how does this really, what is the breakup of this? So despite people of color making about 34% of the population, they are 43% of essential workers. Therefore, they don't have the luxury to work from home. They have to be out there getting that exposure and potentially placing them at a higher risk of this disease. But beyond that, the same social determinants of health that lead to the higher rates of heart disease also lead to the higher rates of COVID-19, again, with structural racism at the core. One social determinant of health that I really want to focus on when it comes to COVID-19 is gender, because interestingly enough, we are now through COVID-19 really trying to study the differences from gender and hopefully beyond that, a race and ethnicity perspective. And one thing that we noticed very early on were that men were dying or having more severe forms of COVID-19 at much higher rates than women. One reason this may be is that men tend to have more common pre-existing comorbidities that place them at a higher risk for these severe infection, be it heart disease, hypertension, diabetes, renal disease, or cancers. Beyond that, we know that men may engage in more higher risk behaviors such as smoking, alcohol use, or having certain occupational exposures. But beyond that, from actually a more scientific perspective, we know that the immune response, specifically the immune system, about 60 genes are on the X chromosome, and women have 2 X chromosomes where men only have 1. So perhaps that protects us as women to have a more innate immune response. Beyond that, though, one of the receptors that allows the actual virus to get into the cells, interestingly enough, we know that estrogen can help prevent the actual ability for that receptor to work appropriately. And all of this has only been really looked at, again, over the past several, even within the past year. But what this pandemic has highlighted is the importance of looking at women and men very differently when it comes to their vulnerability of diseases, but more notably, how we best should treat these diseases. And one further thing I think that's important to highlight is that we have since concluded that pregnancy does place one at a much higher risk of having a severe form of COVID-19. So highlighting that and really highlighting other possible disparities is much further important. Now, beyond the clinical aspects of what COVID-19 has done from a gender perspective, we have to think of also the fact that women in particular may be much at a higher rate of getting infections because they're at the forefront of the battle. Particularly when it comes to healthcare, women make up 70% of healthcare workers. Despite that, though, they are unfortunately more likely to have been laid off and furloughed. About a woman is 1.8 times more likely than a man to have lost their job due to COVID-19. So those financial stressors, which can absolutely suppress your immune system, is problematic. Beyond that, though, women are more likely to have frontline roles in hospitality, retail, and healthcare, where they may have more lower paying positions that don't have the ability for paid sick leave or health insurance. And I want to bring up the racial wage gap because economics and socioeconomic status absolutely factors in, and we know it affects our life expectancy as well. When you think about women in general, they make about 82 cents to $1 of what a male makes, but Black women make about 62 cents to $1 of what a male makes. So economic stress from the pandemic, coupled with, again, a lot of what we see, which is systemic racism, mistrust, discrimination, is really at the height of what may place these particular patient populations at a higher risk for conditions like COVID-19, but even cardiovascular disease. And I bring up a phenomenon called superwomen, which I actually highlighted most recently in a publication that I did for the American Heart Association Circulations, Cardiovascular Quality and Outcomes Journal, which is called superwoman phenomenon. And it's a term that helps to describe how Black women may experience early deteriorations due to stress, just ongoing stress from economics, ongoing stress from being just merely being a Black female in America, caused by racism and social and economic adversity. And that, without a doubt, is affecting this Black maternal health crisis that I talked about and brought up earlier on. My fear is that with this pandemic, this crisis is only going to potentially get worse, especially as we know, again, pregnancy does place one at a higher risk for severe forms of COVID-19. So here we go back to kind of the drawing board, knowing that the problem is cardiovascular disease is the leading cause of death, but it disproportionately affects people of color. Here are the causes, adding the social determinants of health to that. But imagine now adding COVID-19. What is that going to do to the cardiovascular systems of our most vulnerable patient populations? And this is something that I could only imagine. So what COVID-19 has already done is that it's delayed, unfortunately, care. The fear of patient going to the hospital and calling 911 because they fear they will get the infection as opposed to deal with the condition, which is their heart. What I want to highlight is that if you are having symptoms, you cannot delay care. You have to call your doctor. You have to call 911 if you're thinking you're having signs or symptoms of a heart attack, because the quicker we get you into the hospital, the safer it will be, where we could actually perform life-saving measures. Beyond that, though, at least earlier on in the pandemic, there were challenges in terms of us making sure that we can continue preventive care. Since then, we've done, I think, a phenomenal job with the use of telemedicine, which I will be touching upon, but at least in the early stages, it definitely affected our ability to allow for prevention, checking your blood pressure, your cholesterol, your blood pressure. But let's talk about the other aspects of this pandemic: high stress, unhealthy eating, becoming more sedentary, unemployment, lack of public transportation, lack of access to food. So what is this pandemic going to do to all the strides we've made when it comes to cardiovascular disease, especially in the most vulnerable patient population? Well, I fear higher blood pressure rates, increased obesity, increased diabetes, and thus increased cardiovascular disease. And what we're already seeing is that this pandemic is affecting our life expectancy. This actually was released about 2 weeks ago, where they actually saw in the National Center that in 2020, Black males lost 3 years of life in just the first 6 months. When you actually look at Hispanic males, it's about 2.5, the same it is for Black females, about 2.5 years of life lost. That's only in 6 months. That implies that our life expectancy is even less than what I had already painted the picture of what it was at the beginning, which again was about 78 years in women and 73 in men. So can you only imagine what this pandemic is doing within the first 6 months of 2020? I can only imagine what it is going to be once we have further data from the entirety of 2020. But I know all this sounds sobering, but the fact is that we have a solution, at least a more immediate solution to the issue of this pandemic. And I really, truly do believe it's the vaccine. And why is that important? So at the very beginning, there was questions about trust, particularly of the vaccine in the Black and Brown community. And I can say very nicely that that trust level has steadily increased, even from 50%, definitely or probably considering the vaccine that were considered Black in September, to increasing to about 62% of the population. But beyond that, it's important for us to actually see not only if the populations are interested in the vaccine, because we know that that definitely has increased, but access, and do they have access to the vaccine? And the reason that's important is because we know that there still remains inequitable care when it comes to even distribution of the vaccine. To date, there are only about 16 to 18 states that are actually separating their vaccine distribution by race. Of all the states that have to date, I do applaud them, because then they're going to be able to make the changes. On average, though, collectively, we know that in the United States, the majority of people who have received the vaccine or have had access to the vaccine are Caucasian and actually female. So it brings us back to the question that I asked at the very beginning: what do COVID-19 and heart disease have in common? And the answer is all of the above. They are currently at the very top of deaths in the United States, and Black people are more likely to die from both, but social determinants of health are really at the core of it. And knowing that you have underlying heart conditions can place you at a higher risk of a severe form of COVID-19. So all of the, unfortunately, everything is actually the answer. And it leads us to solutions. So doing wonderful summits like this, where you can actually get the message out there, is one part of it. We need to have more awareness campaigns that are targeting the most vulnerable patient populations, which include the Black and Brown community. And I really do think that we need the urgency of this pandemic to build more equitable systems of healthcare, using quite a lot of our community trusted leaders, such as our faith-based communities. But beyond that, we want to make sure that our employers, our healthcare systems, and clinicians are acknowledging and working together to eliminate any of these social determinants of health that we see. We also want to improve current research strategies. And again, I think what COVID-19 has highlighted is the importance of gender research. That has always been known in cardiology, but we have to do a better job in enrolling more diverse patient populations. The only way to do that, I really truly do believe, is to ensure that the research team and clinical team reflect the population that we want to target. That will help improve trust, it will help improve compliance, and at the end of the day, improve underlying cardiovascular outcomes. And with that, I always like to end with this amazing quote from Dr. Martin Luther King Jr. Of all the forms of inequality, injustice in healthcare is the most inhumane. And the fact that he presented this and stated this in 1966, and we're still seeing this now in 2021, is mind-boggling for me. But the fact that we're having these conversations, and hopefully we'll make sound change from it, now that we are focusing at the core of what the issue is, which are the social determinants of health, I am hopeful for our future. I'm hopeful for cardiology, and I'm also hopeful to get us out of this pandemic. So with that, thank you so much. And I look forward to our discussion with Dr. Underwood in terms of the questions you may have.
Thank you very, very much, Dr. Bond. That was really an incredible presentation and update on the impact of COVID-19, particularly as it relates to cardiovascular disease on our communities. You've really covered most of the bases that I really wanted to touch on, but we do have a question from the audience that I want to give to you now. And that is, what is the medicine that Blacks should ask for if they're having a heart attack or if they have heart failure?
Absolutely. So when we think about a heart attack, you're going to be coming into the hospital system, and your doctors are really they need to be encouraged to provide you just the standard guideline treatment. So what is that? A baby aspirin, if not actually a full dose aspirin when you initially come in. In addition to that aspirin, there are other medications that thin out the blood and work very nicely with the aspirin to help stabilize that area or that plaque that had just ruptured. Beyond that, though, you're going to want to make sure that you're on a medication to lower your cholesterol. Beyond that, you also want to make sure you're on a medication that usually helps to control your heart rate and your blood pressure, something called a beta blocker. And most importantly, you're going to want to question the doctor if you had a heart attack, if you need a procedure called an angiogram, which again is that procedure where we look in the arteries of the heart. We basically access it through the wrist or the groin, and we're able to provide contrast, which is dye, which lights up the arteries of the heart and sees if there is a blockage there. And if there is a blockage, we open it up and we're able to provide better circulation to the area of the heart that's lacking. If that heart attack led to your heart muscle becoming weaker, such as heart failure, beyond that beta blocker, you may want to talk to your healthcare doctor about other agents. These agents work through the kidneys, and they actually help to really remodel the heart or build it up again. So that way, if there are any issues moving forward, our hope is that it will allow your heart muscle to recover back to the state that it was. So I think the most important thing to say is that you want to make sure that you're receiving everything that the guidelines suggest. And if you're not, you want to question at the end of the day why that is the case. Advocating for yourself is the first step. And I think if you bring it to the attention of your clinician, they will be more likely to empathize with the fact that they may have missed something and not considered something for you because of potentially unconscious bias or what may be, but hopefully you will help in making sure that they're treating you appropriately.
Absolutely. Thank you very, very much. I think we're running up on time, but I would like to invite everyone to visit some of the items that we have in the Hall for Hope and Health, and also to reach out to Dr. Bond specifically to ask her any other questions that you may have. It certainly has been a pleasure having you at our session. I hope that you enjoy the rest of the FIBCO Virtual Health Fair. This has really been a pleasure, and enjoy yourself. Thank you very much.
Hi, thank you.